Hey, healthcare friends, do you dread doing your notes every day? Do you feel like you can never get ahead of charting? If you're shaking your head yes, keep listening. Freed AI is a medical scribe on a mission to free clinicians everywhere. Freed AI listens, transcribes, and writes medical documentation for you, written in your style and ready the moment the visit is over. All you have to do is give it to your patient. Just imagine leaving the office at the same time as your last patient. Freed is HIPAA compliant, secure, and takes less than 30 seconds to learn. Artificial intelligence cannot replace you, but it can do the administrative work that no human should be subjected to. Get back to doing what you love, helping your patients, and let Freed AI do the rest. Hey all, welcome back to the Real Life Pharmacology Podcast. I am your host, pharmacist Eric Christensen, and I thank you so much for listening today. As always, go check out that Top 200 study guide. It's a 31-page PDF, absolutely no cost to you. Simply an email will get you access to that. So that's at reallifepharmacology.com. All right, the drug of the day today is Linagliptin. Brand name of this medication is Tradjenta. This is classified as a DPP-4 inhibitor. It has anti-diabetic activity, thus lowering blood sugars. And mechanistically, how it does that is it inhibits dipeptidase 4. That's the DPP-4, which is much easier to say. So this is an enzyme, and ultimately, by inhibiting this enzyme, we prolong the action of incretin. And if you remember from GLP-1 agonists, incretin is an important hormone in kind of the homeostasis of glucose, blood sugar, and those type of things. So those incretin hormones, GLP-1, and GIP, so that's glucose-dependent insulinotropic polypeptide. These regulate that glucose homeostasis, thus increasing insulin synthesis is one of their roles, as well as facilitating that release from pancreatic beta cells. Also, they can help with reducing glucagon secretion from the pancreatic alpha cells as well. So ultimately, reduce glucagon secretion. That's going to help lower hepatic glucose production. And also, with the incretin hormones, those are going to help in response to a meal, in potentially promoting fullness and that type of thing, which ultimately can help reduce blood sugar as well there. So the easiest way I remember these is they are in the same line of thinking, the same action as GLP-1 agonists. Essentially, the big difference is with GLP-1 agonists, we're providing exogenous GLP-1, and with the use of DPP-4 inhibitors, we're trying to kind of preserve the body's own supply. So that's kind of the difference, and that kind of explains, I think, why GLP-1s tend to have a much more potent effect on blood sugar lowering and A1C lowering. Okay, so DPP-4 inhibitors like linagliptin, they don't have as potent of a reduction in A1C as GLP-1 agonists. That also explains why we wouldn't use these medications together. Okay, so they kind of work along a similar pathway, and we wouldn't want to have the additive effects there. Kind of similar like to ACE inhibitors and ARBs, how they kind of work a little bit differently, but they work on the same pathway, and so we wouldn't use these medications together typically. All right, so dosing of this medication, it is once daily, so that's advantageous. It is oral, so that's advantageous. Administration with or without food isn't too big a deal there, so that's a nice benefit there. So what's the difference with some of the other agents in this class? So sitagliptin is probably the one I see used most commonly, brand name Januvia. Linagliptin, it's probably the advantage that's most well known or understood is that In patients with poor renal function, it isn't as strongly eliminated by the kidney as sitagliptin is. So typically we don't need to do much for dose adjustments there. Compared to sitagliptin, that's definitely a more important thing to monitor and pay attention to. Linagliptin is still, at this point of this podcast, is fairly expensive, so that's a downside, but so are some of the other newer agents like SGLT2 inhibitors, GLP-1 agonists, and I would say DPP-4 inhibitors have kind of fallen out of favor a little bit. And one of the big things is we don't have the other proven benefits that SGLT2 inhibitors and GLP-1 agonists have, such as the cardiovascular benefits, the renal benefits that go along with those classes. That hasn't been proven as well for the DPP-4 inhibitors and for linagliptin here. All right, adverse effect profile. So drop in blood sugar, I think that makes sense. We can drop it too low. Hypoglycemia is probably the greatest risk, particularly when we're on insulin or sulfonylureas, for example. There has been some muscle pain, achiness maybe associated with this medication, skin reactions, hypersensitivity reactions. Rare adverse effects may worsen heart failure, but actually linagliptin is probably not implicated in studies as much as maybe other DPP-4 inhibitors. And then pancreatitis has been associated with this class of medication as well. So again, very, very rare adverse effects, and even like some of the arthralgia and skin reactions, those are pretty uncommon as well. So again, not likely to cause hypoglycemia by itself, but if we use them with insulin, if we use them with sulfonylureas, obviously that risk goes up significantly. Now, I did want to mention, obviously, we're going to monitor A1C with this medication, using it for the treatment of diabetes and hyperglycemia. So its A1C lowering effect isn't quite as potent as some of the other agents. Typically, you're going to be in that 0.5 to 1 range for its A1C lowering effect, or at least that's what the studies kind of indicate. Where do we use this medication? It's typically going to be kind of an add-on therapy. Maybe somebody that's in that, 8 to 9, 9.5 range, where we want to get it down a little bit further, get it a little bit closer to goal, and maybe we've got contraindications to some of the other agents or something. So that's kind of the role I typically see. Occasionally, you may see it used in geriatric patients. Let's say, maybe they've got contraindications to some of the other medications, and we don't want to use sulfonylureas because they may be at risk for hypoglycemia. And again, they're kind of right in that kind of moderate range where they're slightly above goal, but maybe we don't want to have too aggressive of a goal because they're elderly. That's kind of a role I have seen this class of medication used. All right, let's take a quick break from our sponsor, and we'll wrap up with drug interactions. If you're in the market for any pharmacist board certification study material like BCPS, ambulatory care, geriatrics, BCMTMS, or NAPLEX, go check out meded101.com/store. We've got tons of resources that have helped thousands of pharmacists and pharmacy students prepare for their exam. So go check that out, support the sponsor, help keep this podcast free and available for all to benefit from. All right, finishing up with drug interactions, and this reminds me that I do have a drug interactions book on Amazon that you can certainly check out. But with that said, linagliptin drug interactions, it's going to be a lot of the standard things that go along with medications that lower blood sugar. So the additive hypoglycemia drug interaction, sulfonylureas and insulin, I alluded to that already. Corticosteroids, they can definitely try to counteract what we're trying to do with linagliptin. So steroids can raise blood sugar and oppose the beneficial effects. The beta blockers masking hypoglycemia, if that's an adverse effect with linagliptin. Again, usually we're on insulin or something else with that, but beta blockers have been known to kind of mask those hypoglycemia symptoms. And then because they work on the same pathway, GLP-1 agonists should be avoided with linagliptin. Angioedema type reactions have been reported, so ACE inhibitors, ARBs, could increase that risk. Entresto is another good example of a medication, sacubitril valsartan, that may increase that risk as well. And then last but not least, there is some CYP3A4 metabolism with that medication. So like CYP3A4 inducers, like rifampin, for example, these can ultimately reduce concentrations, which would ultimately make the medication less effective. All right, well, that's going to wrap up the podcast for today. Thank you so much for listening. If you enjoyed this episode, do me a huge favor, leave a rating review on iTunes or wherever you're listening. Greatly appreciate that. Support the sponsor, meded101.com/store. Tons of books, tons of resources, all sorts of good stuff there that can help you become a better healthcare professional and understand pharmacology a lot better. So, again, go check that out. Please support the sponsor, meded101.com/store. If you want to reach out to me, suggestions, comments, recommendations, mededucation101@gmail.com. You can also connect with me on LinkedIn, Eric Christensen, PharmD, BCPS, BCGP. Thank you all so much for listening. Take care, and I hope you have a great rest of your day.